Hi, my name is Rachel and I'm a nursing student at Glacier Hills Care and Rehab Facility. I'm going to present to you a patient now. The patient is a 76-year-old Caucasian female. She was formerly employed by Ford Motor Company. Her reason for admittance was to follow up on her hip replacement on March 3, 2015. Her fractured right humerus and left tibia are being monitored as well. The fractures in her right elbow and ankle occurred after she suffered a fall due to her inability to walk following her hip replacement. This complicated the further treatment of her hip, so patient is now in physical therapy for both the hip and broken bones. The cause of her hip replacement was osteoarthritis and osteoporosis of her right pelvic and femur regions. The severity was so intense that it was not alleviated with conservative measures such as medications. As a result of a stroke that occurred in the early 1990s, the patient has weakness on her right side, especially in her lower extremities. Because of this, she experiences no pain in the region of her surgery, and it does not differ in intensity at any point. The patient states that her hip replacement does not interfere with her daily activities of living, but that the fracture in her left tibia makes it difficult to walk. The patient has no history of severe childhood illnesses. She has a history of osteoporosis, osteoarthritis, hypertension, and tachycardia. She has no history of any kinds of mental illnesses or dementia. Patient is up to date on all immunizations. She receives her flu shot every year and is up to date on her pneumonia vaccine. She has no known drug allergies. On March 3, 2015, she had an open reduction and internal fixation of her tibial plateau fracture. She received arthroplasty, acetabular, and proximal femoral prosthetic replacement. She had a previous cardiac catheterization, and she was also hospitalized for her hip in March. Her current medications include numerous medications regularly for hypertension, osteoarthritis, and pain. She is also on gabapentin to prevent seizures and ondansetron to prevent nausea and vomiting. The patient states that she is a non-smoker and does not drink alcohol. She previously exercised 3 to 4 times a week before fracturing her ankle. At home, the patient states she usually got 5 hours of sleep, but at Glacier Hills her sleeping patterns vary. She maintains adequate nutrition and does not consume caffeine. The patient is single with no siblings, but she says she has many friends. Both of her parents are deceased. She states that she does not perceive any outside stressors or environmental hazards in her life. She has no religious beliefs. She has a college degree and is currently on Medicare for her health care. She has a known family history of chronic illnesses such as heart disease. Her father passed away of lung cancer. The patient's musculoskeletal illnesses are of main concern, so it would be important to perform the musculoskeletal exam. The patient denies presence of swelling, redness, warmth, or deformities of her joints. She does state that she experiences chronic pain in her right elbow because of the fractures. She reports weakness in her right side because of her stroke, so she has limited range of motion there. She also has limited range of motion in her left ankle due to the fracture. She has weakness in her right side and reports changes in mobility due to her hip replacement. It is slightly harder to walk. There is no change in muscle strength. She does not state any assistive devices. The patient does not know her history of arthritis. Upon examination, the muscle mass and bone structure are normal for the patient's age. Her posture was normal, slightly hunched. I was unable to assess for the patient's gait or scoliosis. There was no presence of TMJ. She had diminished range of motion in the right side of her neck, her right shoulder, and her left ankle. There was full range of motion in all other places. I was unable to test for the range of motion and muscle strength of her hip muscles. The strength was diminished in her right extremities, but was normal on the left side. Because of the patient's history of tachycardia and hypertension, a cardiovascular assessment would be necessary. The patient experiences occasional chest pains that is alleviated with medications. She has arm and jaw numbness of the right side, none present on the left side. She has no known history of heart disease, hypertension, or murmurs. She states no change in exertion tolerance or fatigue. She has no difficulty lying flat. There was no palpitations upon examination. Her contour of her chest appeared normal. Upon inspection and palpation, there were no heaves or lifts present over the aortic, pulmonic, Erb's point, tricuspid, or mitral areas. Upon auscultation of the 5 key areas with both the bell and the diaphragm, and the patient sitting up and supine, the normal S1 and S2 sounds were present. There were no murmurs. I was unable to roll the patient on the side in order to auscultate for S3 and S4 sounds. The first pertinent system would be neurological. The patient suffered a stroke over 20 years ago that has left her with some physical damage. Along with this, there may be some underlying neural damage that may affect her as well. Studies have found that stroke is the leading cause of long-term disability worldwide. This is related to the impairment of mechanisms such as synapses in the brain that are affected after a stroke. Focal brain damage caused by a stroke may lead to further motor deficits in patients, especially the elderly. Given the patient's already limited mobility due to the hip replacement and fractured bones, it would be imperative to continually monitor her neurofunctioning to ensure that no further damage has been done. The pertinent system number 2 would be the peripheral vascular. Due to the patient's history of hypertension, peripheral vascular assessments would be good in order to monitor for blood clots or other peripheral vascular diseases. One study found that hypertension was one of the leading risk factors of peripheral arterial diseases of the thighs, buttocks, and calf regions. Individuals with peripheral arterial disorders were more at risk for cardiovascular disease as well. Given that the patient has a history of hypertension and tachycardia already, it is especially crucial to monitor for symptoms of peripheral arterial disease due to its harmful cardiac effects. It would be imperative to continually assess changes in the pain of the patient's legs, edema or loss of hair, or varicose veins present. These are all symptoms of a peripheral vascular disorder, which could be deadly if not found early enough.